Well, I wanted to thank you as a prospective resident for our residency program. Thank you for coming and viewing this section on our internal medicine training. My goal today is that we would just share with you a bit about what you could expect for your training in internal medicine if you came to our residency program. So first of all, I wanted to introduce to you Dr. Stephanie Carroll, who is an internist and a hospitalist at Gunderson Health System. Mm-hmm. Thanks for coming and being with us today.
You're welcome.
Dr. Carroll, would you just share with us a bit of your journey, how you got here and
Sure.
those kinds of things?
Sure. I did my training, initially did medical school in Milwaukee at the Medical College of Wisconsin, and then came here actually to do a preliminary medicine year. I was going to be an anesthesiologist.
Really? I didn't know that.
I did, yeah. Did 4 years of anesthesia and decided I missed medicine, so I came back to Gunderson to complete an internal medicine residency.
Oh my gosh.
Liked it here that much, yep. And then really liked it, stayed on staff as a hospitalist. I started in 2005.
So you would bring the perspective both as a faculty member and as a learner here.
Absolutely.
As a TY resident, probably, and then as a full internal medicine resident. Well, that's awesome. Thank you. I didn't even know that, so that's great. You've agreed to take on this role of being a liaison for our internal medicine residency, so I wanted to thank you for that. What have you enjoyed most about your time here at Gunderson?
Well, I think Gunderson is a fantastic place to do your training and really to practice. So the thing that struck me here the most, I think, since day number one is it's a very team-oriented environment. I think people here genuinely enjoy their jobs and enjoy taking care of patients and working together. And so as a learner, I found that a very comfortable position to learn in. And as a staff doctor, I just enjoy working in that environment. Really, the culture here is to bring academics to a community-sized hospital, which is also, I think, very unique to Gunderson. And so within the hospital system itself, we have other residents that we've been working with for years and are able to really come up with a structured teaching environment for them, but also a more volume-based hospitalist experience for them. So we kind of have the best of both worlds.
Yeah.
And I think that's very unique to Gunderson.
Yeah, that's really, really neat. I think the other thing that strikes me about maybe learning internal medicine here, we live in a good-sized community, so we get a good amount of just bread and butter internal medicine, but we're also the referral center for a huge tri-state region. Helicopters bringing very ill people in. Is that what your experience has been?
I couldn't agree more. Yeah, we definitely have enough volume of bread and butter medicine that I think residents leave here feeling very confident in managing those patients. But you do get the complex, mystery patients here as well. And so the learning from those cases is also, we have both. And then the ones that we, simply are above us, we're surrounded by other facilities that also can take care of some of these patients. So again, we're in a good position to train people here, I think.
That's great. It's a few other things I know that are true. You've been training residents of all types, from general internal medicine, obviously at the heart of the general internal medicine training, and then transitional year residents, podiatry, oral maxillary facial, and even family medicine residents from other places. How has that gone, and how do you think they fit in, and how are they treated?
Sure. What we've done is we've created a structure within the hospital that allows us to have formal teaching services that are protected by hospitalist services that manage higher volume. And so early on in training for residents, we're able to give them that structured rounding where the teams are capped, their number of admissions is capped. We're able to maintain a steady census on those cards. They have time to card round, they have time to review their patients, time to look things up. And so they're very structured. But then
so just if I could interrupt, that's really the first 2 months of their medicine here, isn't it? It's like that really academic environment with people sitting down, talking cases, differential, all the academic teaching like you'd find at maybe the University of Minnesota, University of Wisconsin.
Very similar.
Yeah, very similar to
that. And then what we're able to do in addition to that is really we've developed more of a hospitalist type rotation for our current internal medicine residents where they're exposed to higher volumes of patients and they're learning more on the go.
Yeah.
They're still teaching, but it's in a less formal, less structured fashion.
Yeah.
And they're managing their own patients, and they're really in charge with the attending doctor facilitating their learning.
That's awesome.
It is, and so as we look to developing our family practice rotation, it's kind of exciting because I think we can do a lot of different things to meet the needs of the family practice residents.
That's awesome. So you're really molding this with their kind of experience.
Mm-hmm.
And that then would be in their second and third year,
Yep.
where they get 2 months in each year, higher volume, more independence, less supervision, but plenty of supervision. I know that there's plenty of supervision on those
Right.
teams. And I understand you're going to be bringing in family medicine faculty on those teaching services
Right.
too.
Right, and so the family medicine service will have, part-time will be hospitalists rotating with those residents, and the other part-time will be the family medicine doctors coming in. So they're going to get perspectives from both fields.
Great. What about, what kind of card number are you thinking in those second and third year rotations?
And so, realistically, we're looking at probably a census cap of around 14.
Okay.
I think that the team, the way I see it structured initially, is a doctor and a senior
Okay.
resident.
Yeah.
And so, that 14
Very doable.
seems like a reasonable cap. And again, I think the structure is such that if we find that cap isn't working, we can make adjustments.
Yeah.
Because we do have these hospital services that are managing a lot of the other volumes, and so it allows us to structure the teaching teams in a way that best suits the learners.
That's awesome. That sounds great. What kinds of patients do you and so in the first year, again, just to recap, those more complex patients, really broad differentials, difficult referral cases. Second, third year, what kind of patients do you typically see on your hospitalist services?
So it's a really wide range of patients. We really admit all of the medical subspecialty patients, and so you get the experience with managing those types of patients. In addition to the family medicine residents rotating through on the cardiology service and the critical care service, they actually get a lot of critical care experience on the hospitalist or the general medicine services.
Yeah.
We do have an open ICU, and so we're managing patients that have sepsis, that have GI bleeds, in the critical care unit side by side with the critical care doctors. And so it's a really broad range of patients and really a nice variety, I think.
So what you're telling me is in their second and third year, although they will have a formal ICU experience their first year, second and third year, they're still going to be in and out of the ICU and doing that
Absolutely.
kind of work. And I think that's really important so they're comfortable when they go
You
out
bet.
to do that. That is really great. I know you have that experience too. Could you just tell me a little bit about, in the first year, they also have months of cardiology and formal ICU. What have those experiences been like?
Sure. Both of those services are really structured in large part, or really structured a lot like the teaching services, the structured teaching services. And so as the residents rotate through in there, they're getting didactic learning from the staff doctors, from the cardiologists, from the pulmonologists, in addition to higher volumes. And so it's really structured learning, but they do see a nice variety of cardiac problems when they're on that service. And so, we sort of augment that learning, but the core things are learned during those 2 months.
Great. With all these learners, you still think there's enough volume for us?
Plenty.
Plenty? There's plenty of internal
Plenty.
medicine out there, isn't
Absolutely.
there? So that is really awesome. I hope that really sounds like a program that I'm very excited for our learners to have. My last question for you would be, what do you think has been the attitude of internal medicine toward the family medicine residency and bringing those learners on?
I think we're really looking forward to the opportunity. As we've structured some of the teaching teams more, we've brought in the hybrid residents. As hospitalists, we don't get quite as much exposure to the residents as we used to, and I think we're missing that aspect. And so this is another opportunity for us to teach. And again, really, the culture at Gunderston is about teaching.
It is, isn't it?
And it, you know, as a staff doctor, that's how you continue to learn.
Yeah.
So we're really excited about the opportunity, and excited to keep our hands in teaching where we can.
That's awesome. Well, thank you for two things. Number one, for being with us today and telling us a little bit, but also thank you for taking on the role of being the liaison to our residency. I am really looking forward to it.
Me too.
Okay.
Thank you.
Thank you.